Hi, I'm Vicky, one of the teacher practitioners. I work mostly in hospital pharmacy and I'm currently working as a pharmacist at the Royal Berkshire Hospital, where you will be attending your hospital placements. Today we're going to go through responding to symptoms, skin, part 1. You'll have another lecture on skin later on in the term. The aims are for you to be able to describe the common skin problems that will present in community pharmacy and how to manage them. Hopefully by the end of the lecture you will be able to list the different skin disorders that you see in community pharmacies, know how to differentiate between the different conditions based on symptoms from the patient's history, be able to structure your questioning so you can gather the appropriate information for you to be able to make decisions on how to treat the conditions, whether that's with over-the-counter products or non-pharmacological interventions, and also pick up on those warning signs and when you need to refer patients to another healthcare professional. Skin is the largest organ in the body and it has quite a complex structure and has many functions. It's important for you to be able to differentiate between conditions that can be managed appropriately without referral, so within your community pharmacy, and those that require follow-up and further investigation with the GP. The first thing we need to do is make our diagnosis. To make our diagnosis, we need to gather lots of information, and generally we use this acronym WHAM for this, and by the end of the term you'll be very familiar with it. So first of all, W for who is it for? Somebody arriving in your community pharmacy asking for advice, they're not necessarily asking for themselves. We need to find out who it's for, and depending on who it's for might dictate which preparation or treatment that we recommend. W for what are the symptoms? Is there a rash? Is there any bleeding, weeping? Where are the symptoms? How bad are they? H, how long have they had it? Is this a new problem or is it a long-term problem? H, have they tried anything? So have they tried any medication so far and has it worked? And then finally, M, for any other medication. So do they take any medication for any other conditions, and what other medical conditions do they have? One benefit of skin conditions is we can actually see it, which helps us with our diagnosis a lot. It makes our diagnosis a lot easier. As pharmacists, we are very accessible healthcare professionals, and there's a real rise in people accessing their community pharmacists as the first port of call for healthcare. Rashes, first of all. So a rash is not a disease, it's a symptom of a disease, and it means there's something underlying that has caused the rash. So possible causes are conditions like eczema, psoriasis, there might be infections, allergies, or some kind of infestation. A non-blanching rash is a rash where if you press it, it does not disappear. So we often use a glass to do this test because you can see through it, and it's often referred to the tumbler test or the glass test. If anybody has a non-blanching rash, this could be a sign of sepsis, blood poisoning, and urgent referral is required, preferably to A&E, depending on what other symptoms they have. Eczema and dermatitis are the most common skin conditions, and their terms tend to be used interchangeably, but we're going to have a look and see what similarities and differences there are between them. Atopic eczema is an allergic condition. It's quite common in children. About 20% of children have it, although it's not always children. About 2 to 10% of adults have it too. So often there are other health conditions that can increase the risk of eczema, things like asthma and hay fever. There can be many aggravating factors, so here are just some examples, things like pollen, sweat, detergents and soaps. It's often useful to ask whether they've changed any soap or detergent recently. Cosmetics, rubber gloves is a common cause. And for hairdressers, using things like hair dyes and colouring can cause issues. These are the common presenting features. Many skin conditions have the same features, so it can be really difficult to distinguish between them. This is the referral criteria, and this is where we need to refer to the GP for further investigation, because generally over-the-counter products are not available. So any failure of treatment, presenting on the face. So this, for eczema presenting on the face, the first line would be to use an emollient, but if this fails, we would use a corticosteroid. Corticosteroids you cannot buy over the counter for use on the face. So this is why generally we would say if they've used an emollient, you need to go and see your GP. Any children, anyone pregnant or breastfeeding, any broken skin or red flag symptoms. Those red flag symptoms are where there's any bleeding, weeping, or any sign of infection. So signs of infection are worsening of inflammation, any weeping, any pustules or crusting. Over-the-counter treatments available are emollient and topical steroid. The product license for these products allows us to sell them over the counter under certain conditions, and if they're out of those conditions, as I said with the hydrocortisone, then the patients should see their GP for treatment. We can also give some practical additional advice. We don't always need to sell a product, and we are there for just general healthcare advice as well. So practical things we can say, try and avoid the triggers if they know what the triggers are. Certain fabrics irritate the skin, so try and avoid wearing these. So things like cotton are best. Heat can make things worse, so try and keep rooms cool and avoid using soaps or detergents that will affect the skin. Contact dermatitis is an inflammatory response of the skin to an irritant. So when you're doing your WAM questioning, you need to find out how much of the irritant has been in contact with the skin and how much of the skin. So for example, something like swimming for an hour, your body is going to be totally submerged in the water or the irritant, or just washing hands for a minute will be a short time with a restricted area of skin exposed. Common aggravating factors are again detergents and soap, cosmetics, rubber and rubber gloves, hairdressing, hair dyes and colouring, and for people like builders, it might be cement or nickel in jewellery is a common one. So as you can see, there's very similar aggravating factors here for contact dermatitis as there is for eczema. Presenting features, as you can see, are very similar to those for atopic eczema. So here are some examples of some contact dermatitis. So here you can see the henna tattoos, and there has been a reaction around the product applied to the skin, and there's slight reddening there. And then the second picture is somebody who's had worn a necklace, perhaps a nickel necklace, and that has caused an inflammatory response in the skin. As we go through the lecture, the pictures, I'm afraid, get a bit more gruesome, so beware. Referral criteria, so these will be very similar to those of atopic eczema, so children, anyone who's pregnant or breastfeeding. If there's any signs of infection, so broken skin, if it's bleeding, weeping, because those might require antibiotics, which will have to be prescribed by the GP. Is it widespread, so is it spreading all over the body? And of course we have that non-blanching rash. How do we treat? So it's emollient therapy and topical steroids, the same as atopic eczema, but the most important thing to do is remove that causative agent. Additional advice, remove the trigger, try to avoid scented fragrance products because that can aggravate sensitive skin. Use protective clothing if you know you have a reaction to a certain a certain product, use protective clothing when you're using that product. Try and change the product to alternative products that don't cause you emission, and use a regular use of emollients. So those medicinal products available for skin conditions, we have emollients, topical steroids, antifungals, antiseptics and antihistamines. The main aim of emollients is hydration, and they form a protective film across the skin, preventing water loss. And so therefore they're used for dry scaly conditions like eczema and psoriasis, and restore the integrity of the skin. Once the skin does crack, it's much more difficult to treat, so it's important to apply as much as is needed to prevent this happening. Emollients are available in lots of different forms, so you've got creams, ointments, lotions, sprays, and they can also be used as a soap substitute. They're available in shops and pharmacies, and they can also be prescribed by the GP. They are quite expensive when you're buying them in large amounts over the counter. You might want to use an ointment at night and a cream in the morning, because an ointment is more effective, but it's more greasy. If using a corticosteroid as well, it should be applied at least half an hour before the corticosteroid, and that avoids dilution of the steroid and also spread to unaffected areas. You can have a look in the BNF for tips on emollient applications, and that will give you some more information. There are different types of emollients as well. So you've got occlusive emollients. They create a film over the skin, preventing the water evaporating. Humectant-containing emollients contain additives like urea or lactic acid, and they attract and hold water to the top layer of the skin. Some emollients have ingredients in them to help stop itching. And there are also antiseptic ones, so they contain an antiseptic to help prevent infection. Topical corticosteroids are used for inflammatory conditions, and they reduce the inflammation and skin irritation. They should only be used in small amounts. And here you can see two products. We've got hydrocortisone and clobetasone. So the clobetasone is the actual drug name ingredient, and Umivate is the brand. They are available in different potencies. So there's mild, moderate, potent and very potent. You can have a look in the BNF, and that will give you some information about which corticosteroids are which potency. Side effects are rare with short-term use. They're much more likely with long-term use, but particularly more so with the more potent steroids, which is why the more potent ones are prescription only. Over-the-counter products are limited to a 7-day use. I mentioned earlier that there are some restrictions to using corticosteroids over the counter. So for hydrocortisone, it can only be used for those aged 10 and above, and for clobetasone, 12 and above. We cannot sell corticosteroids over the counter for use in pregnancy and breastfeeding, although if you check the BNF, they can be used under supervision with by a dermatologist. Although for use over the counter, we cannot recommend or cannot sell it over the counter for these people. I mentioned that you can only use them for up to 7 days. They can be used twice a day. We can only sell a 15-gram tube, and only one at any time. They should not be used on the face, which I mentioned earlier, but also the anal genital area, any broken or infected skin. And this is why it's important to use lots of emollients on this area of skin to prevent that happening. If it was to be used on any damaged or broken skin, then it would really sting. Topical corticosteroids should be used sparingly and applied thinly. So here's some guidance on how we can do that. We use 1 fingertip unit. That's the amount of cream that can be squeezed from a standard tube along an adult's fingertip. And this amount of cream should be enough to treat skin twice the size of the flat of an adult's hand. Antifungals are also available over the counter, and they kill fungal cells by affecting the cell walls and causing the cell contents to leak out. There are lots of different formulations available, so creams, sprays, gels, powders, and it's important that you involve the patient in their treatment choice. And this is what we call patient-centered care or shared agenda, which you will hear a lot through your course. So now we have come to a typical multiple choice question that you could get typically in an exam. Leslie comes into your pharmacy stating she's had an allergy to a spray and lists his symptoms. Which one of these would be a red flag? So have a little think and we'll go through it in the next screencast.